Welcome to Derm Drop, your TLDR in dermatology. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other interesting sources in the dermatology community. Episode 12 includes segments on the role of hormones and birth control in rosacea, the role of sweat and antiperspirants in hidradenitis suppurativa, the relationship between Dupilumab and ear infections, and how to treat psoriasis and psoriatic arthritis in patients with cancer. So let's get started. Our next segment is on the association between birth control and rosacea. If you've got a young female patient with stubborn rosacea, ask about her birth control. Progestin-based contraception methods can both trigger or exacerbate rosacea. That's because progesterone promotes vasodilation by increasing synthesis of nitric oxide in the endothelium and by inhibiting calcium channels in vascular smooth muscle cells. By the way, progestin is synthetic progesterone, in case it's been a minute since your OBGYN rotation. While these mechanisms produce the rapid flushing characteristic of rosacea, progesterone can also influence gene expression, resulting in long-term effects such as background erythema. Progesterone also promotes sebum production, and as you know, the increased oil mixes with dead skin cells and clogs pores, resulting in acne. To assess the impact of progestin-releasing intrauterine devices on the development of rosacea, researchers from Drexel University College of Medicine compared incidence rates among hormonal, i.e. those containing levonorgestrel, and non-hormonal, i.e. those containing copper, IUD users at 1, 3, and 5 years post-insertion. Their findings, published in the Journal of the American Academy of Dermatology in February 2025, showed that Liletta had the highest incidence rate of new-onset rosacea compared to copper IUDs, followed by Mirena, which was also statistically significantly higher, then Skyla, which was nominally higher but did not reach statistical significance. Kylena was not included in the study, but its progestin potency falls between that of Mirena and Skyla. Rosacea incidence rates increased over time despite tapering progestin release, presumably due to cumulative exposure. By 5 years out, Liletta's incidence rate was almost twice, in fact about 1.8 times, that of non-hormonal IUDs. While not reported in the literature, it's mechanistically plausible that any route of unopposed progesterone delivery could increase rosacea risk. Other progesterone-only contraceptives include Depo-Provera injections, Nexplanon implants, and progestin-only pills, aka POP or mini pills, such as Nora B, Slind, and Opill, which was FDA approved for sale in the US without a prescription in 2023. Plan B, the quote-unquote morning after pill, contains levonorgestrel, the most potent progestin, so could presumably flare existing rosacea, but again presumably would not be taken consistently enough to induce rosacea. Even normal elevations of endogenous progesterone levels in the luteal phase of the cycle may result in premenstrual rosacea flares. Adding estrogen, as seen in combined oral contraceptives, can mitigate progestin's adverse effects. That's why declining estrogen levels in menopause can worsen rosacea, and why hormone replacement therapy improves rosacea for some women. So when Metrogel is not enough, collab with the OBGYN. Shout out to Dr. Rosen for highlighting this study in episode 4 of the Dermatology Digest podcast, Get Lit. Next up, an HS tip. Gel and spray antiperspirants are better tolerated than solid sticks. In a pilot study published in the July 2025 issue of Skin, all 7 patients with Hurley Stage 1 axillary hidradenitis suppurativa, including those who failed other treatments, experienced complete resolution after starting or changing to gel-based aluminum antiperspirants. The researchers also posted their recommendation in a TikTok video, and of the 16 commenters, 94% reported improvement or clearance with gel or spray antiperspirants. Solids are more occlusive, so they contribute to follicular blockage. Gels are less acidic and therefore less irritating. They work more superficially, which also reduces irritation. and they dehydrate sebaceous glands, which reduces sebum production and follicular occlusion. So, gels are not just better tolerated, they may reduce disease activity. But reducing sweat has benefits independent of vehicle. It prevents body odor, duh, and it reduces itch, burning, and pain. And that's not just because sweat pours salt in an open wound. The sweat of HS patients is actually pro inflammatory with upregulated interferon gamma, IL-8, and MCP1, according to a study published in October 2022 in ACTA-DV. Now imagine what happens when that sweat-induced inflammation is multiplied by hyperhidrosis. Indeed, the ACTA-DV study found that HS severity correlated with hyperhidrosis severity. And HS patients are over 3.6 times more likely to have hyperhidrosis, according to a study published March 2020 in the Journal of the American Academy of Dermatology. Treating hyperhidrosis in HS gives clinicians a 2-for-1, as seen in a January 2022 systematic review in Dermatologic Therapy, which showed that botulinum toxin effectively improves quality of life for these patients. But what if there were a hyperhidrosis treatment that is less expensive than Botox and came in a gel formulation that HS patients tolerate? Enter Botanix Pharmaceuticals Sofpironium 12.45% topical gel marketed as Sofdra. If sweat worsens HS and HS patients are more likely to have hyperhidrosis and HS patients tolerate gels best, then Sofdra looks like a good fit for HS patients with comorbid hyperhidrosis, and maybe even for HS patients without hyperhidrosis. HS was misnamed in the early 19th century due to the belief that it was an inflammatory dysfunction of apocrine sweat glands rather than a follicular occlusion disorder. While the name does not quite capture the pathogenesis of HS as we currently understand it, maybe it's not entirely wrong after all. Better HS, no sweat. Does Dupixent prevent ear infections? A retrospective cohort study published July 16, 2025 in Pediatric Dermatology, the Journal of the Society for Pediatric Dermatology, suggests it might. The researchers at West Virginia University looked at the risk of otitis media, both suppurative and non-suppurative, and subsequent surgical intervention in atopic dermatitis patients treated with Dupilumab compared to those treated with pimecrolimus over 5 years. They found that patients treated with Dupi had 40% fewer episodes of otitis media and 27% fewer related surgical procedures. Parents and dermatology clinicians sometimes hesitate to initiate systemic therapy for young eczema patients because shots are no fun for the kiddos and systemic medicines are scary for the parents. But sharing these data points, especially with families that have struggled with recurrent middle ear infections, may provide valuable and compelling information on which they can base their decision. Question: how do you treat psoriasis and psoriatic arthritis in cancer patients? Patients with psoriasis and psoriatic arthritis do get cancer, and cancer patients treated with immune checkpoint inhibitors get psoriasis and psoriatic arthritis. That's because immune checkpoint inhibitors, including PD-1 and PD-L1 inhibitors such as pembrolizumab, aka Keytruda, and CTLA-4 inhibitors such as ipilimumab, aka Yervoy, which are increasingly used to treat a variety of cancers, take the brakes off the immune system so it can attack the cancer. But without brakes, the immune system can lose control, resulting in new onset and worsened autoimmune diseases in up to 80% of patients. So the key is to rein in the aberrant autoimmunity without handcuffing the cancer-fighting part of the immune system. Because the last thing you want to do is suppress the immune system or interfere with the immune checkpoint inhibitor's mechanism of action and worsen the patient's prognosis. With that in mind, a small multi-center study published July 14, 2025 in Arthritis Care and Research looked at 21 patients with immune checkpoint inhibitor-associated de novo or flared psoriasis and or psoriatic arthritis treated with apremilast, Amgen's PDE4 inhibitor marketed under the brand name Otezla. All patients with pre-existing psoriasis without previous apremilast exposure that flared on an immune checkpoint inhibitor had complete or partial response to apremilast. 4 out of 5 patients with de novo psoriatic disease achieved partial response to apremilast, one of which was transient. Interestingly, pre-existing psoriatic arthritis was more likely to flare on immune checkpoint inhibitors than psoriasis alone, and those patients had lower response rates to apremilast, as only 4 out of 7 of those who had psoriatic arthritis flares had complete or partial responses. The researchers asserted that apremilast is, quote, an attractive therapeutic option given that it is not immunosuppressive and therefore not thought to impair cancer responses to immune checkpoint inhibitors. But consistent with Amgen's data and dermatology clinicians' experience, tolerability was an issue. In this study, 30% discontinued apremilast due to adverse effects. And what if the psoriasis or psoriatic arthritis severity warrants a bigger gun? Well, don't use a TNF inhibitor. If the name alone doesn't clue you into the contraindication, a 2023 study of 147 patients published in the Annals of Rheumatic Diseases found that although TNFs reduce the time to immune checkpoint inhibitor arthritis control, they also reduce time to cancer progression compared to methotrexate. IL-23 inhibitors such as guselkumab, aka Tremfya, and risankizumab, aka Skyrizi, might be the sweet spot between efficacy and safety as they are considered minimally immunosuppressive. IL-17s, however, are a mixed picture, with data showing reduced cancer rates in some populations and increased rates in others. Same with methotrexate. So the answer? Treat mild to moderate immune checkpoint inhibitor-associated psoriasis and psoriatic arthritis with a PDE4 inhibitor, and moderate to severe immune checkpoint inhibitor psoriasis and psoriatic arthritis with an IL-23. And that wraps up episode 12. Derm Drop is written and hosted by me, David Sider, with production and distribution by Jacob Gary. Full text and links to the articles discussed in this episode can be found at linkedin.com/in/Dave-Sider, spelled SEITER. Questions and comments can be sent to us at dermdrop@gmail.com. If you learned something useful, hit the thumbs up button and tell a friend. Thanks for listening, and tune in again in 2 weeks for the next episode of Derm Drop, your TLDR in dermatology.